participant packet that you received via email on Monday from Barb. On page 3 is where you'll get all the links for all the sessions today. So if you get kicked out, just refer to that and go back to page 3 and click on the session you want to join. Okay, I think that's all of that stuff. Excuse me. So thank you again for attending. Now I'd like to welcome our first speaker today. Her name is Julie Mansfield. She's a research assistant professor from the Ohio State University. Her presentation is titled Head, Shoulders, Knees, and Toes, How Pediatric Anatomy Affect Injuries. I heard her present a few months ago, and I loved her presentation. It really just kind of help me remember why I do what I do and why car seats are so important. So I think it's a good reminder for everyone to hear her presentation. I'm super excited for it. So Julie Mansfield is a research assistant professor at the Injury Biomechanics Research Center at The Ohio State University. She holds a bachelor's degree and a master's degree in mechanical engineering and a PhD in biomedical engineering. Julie's research focuses on pediatric vehicle safety, especially child restraint system performance and usability. Julie works closely with the industry representatives of Cpst, the Center for Child Injury Prevention Studies. She has been a technician since 2014. Welcome, Julie.
Thank you very much. I appreciate the introduction. Can you hear me okay and see my screen? Wonderful. Okay, so I'm really excited to be joining you here today. You know, these virtual conferences are a little bit different and, you know, there's some drawbacks, but one of the huge advantages is that so many people can get together from all over the world. So this is really great. I'm excited to be here in Indianapolis with you from Ohio. So thank you for having me today. Today, we will be discussing how pediatric anatomy affects injuries. I hope you find this information to be interesting and also helpful as you carry out your CPST duties. The purpose of today's talk is to give you some background information about how children's bodies grow so that you can better explain some of our common safety recommendations to caregivers in the field. We always have a lot of information to share with caregivers, and I believe, kind of like Megan said, that if you can explain, you know, why a safety recommendation is made, then, you know, it's more rewarding for everybody involved, and the caregivers will be more likely to remember that recommendation and be more diligent about following it. A key idea for today's talk is that children are not small adults. Maybe you've heard this phrase already, and I'll be circling back to it several times as we discuss exactly how and why children are different from adults, and why children need to be treated and studied as their own category of passenger. This concept is important because in our field, we have a lot more data about adults than kids. We've been studying adults in car crashes since about the 1960s, especially adult males, and it's really tempting for scientists and researchers to kind of take what we know about the 50th percentile adult male and kind of scale everything down to make it fit for children. However, as we will learn today, that's not really an ideal way to treat kids. There are lots of important differences between adults and kids other than size alone. Another key idea for today's talk is that children grow and change very rapidly. So this is something we all know, but we'll kind of talk about it in specific examples. So, you know, not only are children very different from adults, but children are also very different from each other. So a newborn baby is physically very different from a 2-year-old, and that 2-year-old is different from a 5-year-old. 5-year-old is different from a 10-year-old. So children of each of these ages should be studied carefully because physical changes happen very quickly throughout childhood. So we could talk about a lot of different topics and examples of how children grow and change anatomically. There are entire college classes on this topic, but in our 1 hour today, I'm going to briefly hit on 3 main body regions: the head and the brain, the cervical spine or neck, and the legs or lower extremities. For each of these body regions, I'll go through some of the most important factors that play into protecting children in crashes. So their physical geometry and proportions, so the differences that we can see very easily by looking at children compared to adults. And also some of the changes that are less obvious, such as their bone shapes and tissue strength. We will talk about how their developmental rate plays into vehicle safety decisions, as well as injury outcomes and how children tend to recover from certain injuries in ways that are different from adults. Importantly, we will circle back around to apply this knowledge in ways that CPSTs can hopefully use and share with caregivers at seat checks. Like I said, it always helps if CPSTs can justify and explain why we are making the recommendations that we make to caregivers. It gives the caregivers more confidence in our advice that we're giving them, and it also helps them to remember it. So I hope you find this information valuable and applicable as you take it out into the field as a CPST. So let's move on to topic number 1, the head and brain. This is something that we all already know and we talk about a lot as CPSTs. The child's head is proportionately larger than an adult's in terms of both size and mass. It's part of what makes kids so cute, right? They've got these big old bobbleheads and these big pretty eyes, and we just eat that up because it makes them look different from adults. When a child is born, their head is about 1/4 of the length of their body. The body then grows at a significantly faster rate than the head throughout childhood, and by the time they've reached adulthood, the head is only about 1/7 of the length of the body. Now let's talk about some changes happening inside the head, in the brain, which we can't obviously see by looking. So children's brains change with age. One of the main factors behind the change is because of a substance called myelin. Myelin is a phospholipid or fat layer which surrounds the axons of neurons. So you might remember what a neuron looks like from biology class. A neuron is a specialized cell in our nervous system that transmits signals around the brain and to the rest of the body. They are these long, skinny cells that have their main cell body at one end and their transmitting fibers at the other end. Connecting each end is the long, skinny part called the axon. So electrical signals kind of zoom from one end of the cell to the other along the axon, at which point the little fibers at the end pass the signal on to either another nearby nerve cell or a nearby muscle or gland in your body to tell it what to do. The myelin coating, or the fatty layer that surrounds the length of the axon, helps to speed up the transmission of the electrical signal as it travels to where it needs to go. So the myelin basically helps your nerve cells and your nervous system to be more quick and more efficient. So that's great from a cognitive standpoint. But why do we care in terms of injury prevention? Well, it turns out that the myelin itself deforms very easily. It's just made up of lipids or fats, and we know that fat is very soft and jiggly, right? It doesn't hold its shape very well. So this matters because the amount of myelin in a person's brain cells changes as the person ages. At birth, children have only about 34% of the amount of myelin that they will eventually have as adults. The amount of myelin increases rapidly until the child is about 5 years old, at which point the amount of myelin is nearly equal to adult levels. So this means that young children, have less of this jiggly fat in their brain tissue compared to adults. So you might think of an adult brain as kind of a big bowl of jiggly jello inside their heads. It's great for transmitting brain signals more quickly, but it definitely changes how the brain responds physically when you hit your head or get into a car crash. Along with changes in myelin in the brain, there are also changes in the water content of the brain. So at birth, the brain is about 88% water, but adult brains are only about 78% water. So some of this water is being replaced by the fat in the myelin, which of course has different physical reaction when the head experiences physical trauma. If you look at all of these changes, along with other things that are happening in there, we have data that suggests that children's brains are stiffer than adults' brains when exposed to large forces, such as the forces you would experience in a car crash. To complicate things, this trend does not always hold true when you're looking at different types of physical trauma, like more mild head strikes. But this trend of stiffer child brains seems to hold true for large trauma events such as car crashes. And to further complicate things, age-related changes are not necessarily steady or linear, but happen very rapidly during the first few years of life, and then more gradually throughout early childhood. So there's a lot of different things happening at different rates, like the water and the myelin. So it's not always clear what the total effect on the brain is at any given point in development. And then one more wrench to consider is that the brain is actually a very complex organ. So I've been comparing it to a bowl of jello. but that's kind of doing us all a disservice as humans because our brain is actually made up of very complex structures and different types of tissue in different regions. So you've got your main lobes of the cortex, so the wrinkly part kind of that most of us picture when you think of a brain, you know, what it looks like in cartoons, just kind of the wrinkly folds all over. Then you've also got this separate area in the back called the cerebellum. Deep in the brain, you've got the corpus callosum, which is a big bundle of nerves that connects the right and left hemispheres of your brain. You've got other defined structures such as the thalamus and the pituitary gland. And of course, you've got the spinal cord that comes up from the spine and connects deep in the brain to some of these central structures. So those are some of the things happening within the brain itself. We can also take a look at a little section of the skull and what's happening directly below the skull. So now we're kind of on the surface of the head. So you can see this top layer that we're zoomed in on is the layer of skin or the scalp. Underneath, it's followed by a layer of what we call periosteum, which is like a vascular connective tissue that envelops all your bones. Below that, we see the thick kind of spongy looking layer is the skull itself. So this is an important reminder that bone is not necessarily super dense or completely solid. Bone is actually very light and its structure inside has this spongy appearance. That makes it very strong while still keeping it nice and light so that we can carry our own skeletons around all day. Beneath the skull bone, you've got what's called the Dura Mater, which is made up of a periosteal layer and a meningeal layer. It's basically just another layer of connective tissue that kind of helps hold everything in place and protect everything. Then you've got kind of this interesting layer called the arachnoid matter. Arachnoid, that might be a word that reminds you of something. It comes from the root word for spider. So like arachnophobia is a fear of spiders. And this layer is called the arachnoid matter because it literally looks like a spider web. It's got a bunch of these thin, fine little thread-like membranes that kind of hold and protect the brain below it. Then one more layer underneath that is the pia mater, which again, you're seeing a pattern here. It just helps to protect and hold the brain in place. So if you look on the other side of this photo, you'll see that there are also several spaces or gaps between these layers. We've got the subdural space and the subarachnoid space. These spaces hold cerebrospinal fluid that helps to not only cushion the brain, but also provides nutrients and removes waste. So some of these spaces also provide an area for blood vessels, such as arteries and veins, to pass through. And in a healthy brain, these spaces are small and everything is held in place pretty tightly. However, physical trauma can disrupt some or all of these delicate layers surrounding the brain. Hard head strikes can cause the layers to separate or kind of move in relation to one another. These blood vessels that pass through this area are also interesting because they're long, right? And they're connected to other stuff in the head. So some of them are called bridging veins because they kind of look like a bridge between one area of the brain and another. And you might kind of imagine that if one side of the bridge moves due to trauma and the other side doesn't move, those veins can rupture. And that's basically what happens is a subdural hematoma, which is essentially a bleed between your brain and skull. And that can be very serious. So as you can see, these are just some examples of how the brain is much more complicated than just a bowl of jello. All of these layers and structures respond differently from one another to trauma and impacts, and injuries and disruptions in part of the brain can affect other areas and other functions. The type of head injury that a person suffers might depend on what area of the head was struck and what structures are underneath within the brain in that area. It might depend on what direction the head was struck and how hard it was struck. So we really need to have a lot of information about where and how the head is being hit before we can even begin to understand what the physical response of the brain or the different structures of the brain might be. So we know that people of different ages have different recovery outcomes after brain injuries. So after very severe traumatic brain injury or TBI, we have data that shows that younger children really struggle to recover their cognitive performance, whereas children just a couple years older in the 8 to 12-year-old range tend to have better recovery outcomes. If we look at a less severe or more moderate TBI, we see the trend holds steady where younger children and infants have poorer recovery outcomes compared to older children. In mild TBI, though, cognitive recovery is not well predicted by age, so there are other important factors that might be playing into a person's recovery process. It's interesting to note that this trend of better recovery for older children does not last forever. Once you get into older, kind of elderly adults, they tend to have worse recovery outcomes. So it appears that humans kind of peak during adulthood in terms of the brain's ability to recover from trauma, with the very young and very old people having a harder time recovering the cognitive functions that might be affected. So it's important to talk about head and brain injuries because the head is the most commonly injured region for kids in crashes. Looking at this graph, we're considering children ages 0 to 7 riding in CRSs. The height of the bars show the risk of moderate to severe injuries in each of these body regions. So we're not considering minor injuries like bumps or scrapes. We're only considering serious things like broken bones or other potentially debilitating types of injuries. The head, represented by the red bars, is the most commonly injured body region across all types of crashes. So you can see each cluster of bars represents frontal crashes, near side crash, far side crashes, and rear crashes. From studying the outcomes of actual crashes, we know that the cause of head injuries is almost always, not surprisingly, due to the head striking against something in the vehicle. So the door frame, the back of the front row seat, an adjacent passenger, etc. So the best way to prevent head injuries is to do everything we can to prevent head contact. The way we measure this is by looking at head excursion, that is how much the head moves during a crash. Obviously, if the head moves less, then it has less chance of striking anything within the vehicle. So, what are some specific tips that CPSTs can use to help reduce the risk of head injury? First, for children in a rear-facing CRS, we obviously want to make sure that we have a tight, proper installation. Tight installations help keep the CRS in place, and they prevent the head from traveling too far around the vehicle. We also want to make sure that we have proper space between the back of the rear-facing CRS and the front row seat. This, of course, varies based on manufacturers' recommendations. Some CRS manufacturers want a certain amount of space, while others might allow light touching against the seat back. So you definitely want to check your manuals and check in with your manufacturers there to make sure that you're using each seat as it's intended to be used. Finally, we want to make sure that the weight and especially the height of the child are appropriate for the rear-facing CRS. Usually, we want at least 1 inch of space between the top of the child's head and the top of the CRS, so where that arrow is pointing there. This inch of space or more typically allows the child to ride up or slide up slightly in the CRS without their head coming out of the top of the shell. Even with a perfectly tight harness, kids still tend to slide up a little bit in the seat during a crash as the harness material stretches a little bit and the shoulders kind of fully engage with it. So even if your harness is perfectly tight, it's still important to have at least this 1 inch of space up here or however much the manufacturer recommends. And then interestingly, there is some evidence from some testing at Consumer Reports that it might be even beneficial to transition from a shorter, maybe a rear-facing only CRS into a taller rear-facing convertible CRS a little bit sooner rather than later. In sled testing with both types of seats, they found that over half of their sample of the shorter CRSs allowed head contact against the back of the front row seats, while only 4% of the taller CRSs allowed head contact. And again, we're calling these tall and short with respect to the child within the seat. So if the child is shorter, as long as they have that space above the top of their head between the top of the head and the shell, then that's no problem. But if we take a look at the photos from their test, we can kind of see what's happening. So these CRS both contain the 12-month-old dummy. So we know that it's kind of hit or miss as to whether the 12-month-old will still fit properly into a rear-facing only seat. This is usually about the point where most caregivers should consider transitioning an average-sized child to a rear-facing convertible anyway. So this dummy is kind of at the upper end of what we would consider acceptable for an infant. But at the point of contact in these photos, you can see that the top of the dummy is sticking out of the top of the CRS in the photo on the left, whereas the taller convertible seat on the right kind of keeps the head better contained within the shell of the CRS. Again, this is not saying that infant seats are bad. It's just that, if you put a child in any seat where the head is up near the top of the shell, you want to make sure that they have that extra space, because this is the type of kind of movement that can happen as the child rides upward, and the head could potentially stick out the top of the CRS like this. And here's just another angle of these two conditions, where you can see that having enough space between the top of their head and the top of the CRS is quite helpful in preventing head strikes. So if we switch gears now and think about forward-facing CRS, what are some tips for CPSTs to share to prevent head injuries here? Again, a tight, proper installation is your best line of defense. A tight harness is especially helpful in forward-facing CRS because the harness is doing kind of the full job of restraining the child, unlike in a rear-facing CRS where the back of the CRS also helps to support the child. And as we all know, the main tool for preventing head injuries in forward-facing CRS is the top tether. The top tether reduces head movement by about 4 to 6 inches. In these crash test photos, you can see the difference between a forward-facing CRS installed with the top tether. On the top photo, the head only comes as far as the green line. And in the bottom photo, without a top tether, the head of the dummy extends several inches further up to the red line. If you're interested in viewing the full videos showing these examples, you can search on YouTube for Buckle Up with Brutus. That's kind of our team that has made several educational videos showing these different conditions and a few others. So that wraps up our discussion about the head. Now let's move on to discuss the neck or cervical spine. First, we'll go back to our graph of different injuries. So we've already discussed the head in red, which you can see is far and away the most common type of injury for children. Neck and spine injuries on this graph are shown in blue. So you can see that neck injuries are really not that common, which is good. The catch here is that when neck injuries do occur, they're very serious and outcomes can be quite poor. So even though they're rare, they deserve our attention because of their inherently serious nature. This is especially true for certain age groups of children, which we'll discuss shortly. First, let's look at some anatomy of the cervical spine. So the very first vertebra at the top of our spine is called C1. So C is for cervical, and then they're all numbered 1 through 7. The top one, C1, also has a special name, and that's because it's a little bit unique. It's called the atlas. The photo on the right is an overhead view, so looking straight down on the top part of this bone. This is an adult C1. So the base of the skull sits directly on top of C1, and it's got these little flat divots, or what are called facets, on top. So these little facets are where the skull sits on top of this vertebra, and those little divots allow the head to rock forward and back. So like when you nod your head, yes. The entire vertebra is shaped like a ring, and in the middle of this ring is a protruding part of C2, the vertebrae below it. Part of it kind of sticks up in the middle of that ring and allows the head to rotate side to side. So like when you shake your head, no. So in the adult, the ring of this first spine vertebrae is fully formed. It's a nice complete circle. And there are also 2 smaller arches on each side where the arteries and veins go through. If we go backwards in time and look at C1 for a newborn, you can see it looks very, very different. So the newborn only has 2 small bony regions, which are connected by cartilage only. So this photo here is just showing the 2 bony regions, and the infant just has cartilage kind of completing the arch above the top and around the bottom as well. So you can see it looks quite a bit different from what we were just looking at for the adult. Once the child is about 3 years old, we can see the vertebra starting to resemble the adult ring shape. We see the development of a 3rd bony region, which has formed into this top anterior arch, it's called. And then the other bony regions have grown larger and are closer to connecting to one another. However, there are still some weak points in this ring called sychondroses. These are still regions of cartilage that connect the 3 distinct areas of bone for a child. These are the points that are especially susceptible to injury and remain so until the bones fully fuse together or ossify a few years later. If we take a look at the next vertebra, C2, we see a similar story. C2 is also called the axis because its shape is also unique compared to the rest of your spine. It has this dens or apex that protrudes upward, and it goes through the middle part of the ring of C1 that we were just looking at. So you can see in the newborn on the left that this vertebra starts out as 4 distinct bony pieces, again connected by just cartilage. And then you can see that the gaps have pretty much closed by age 3, but weak points still exist as the bone continues to form and harden and take on its final adult shape. Another interesting feature of the spine to discuss today are what's called facet angles. So facet angles refer to the surfaces of each vertebra that contact the vertebra above and below it. So in this photo, you can see those surfaces highlighted in red. In an adult, as shown in the picture, these surfaces are at a fairly steep angle. So you see the red lines are quite diagonal. And if you envision a force kind of pushing on the side of the spinal column, so maybe coming in from one of the sides, the angle of those facets kind of interlock and kind of help to resist the sideways force. So the assembly of bones is strong because each spine kind of interlocks with the ones above and below it due to these angles between. In a child, however, these facets are, oops, sorry, just lost my spot. Okay, sorry. In a child, these facets angles are more shallow and horizontal. So if you picture these red lines just kind of going straight across horizontally, the spine bones just kind of sit on top of each other like a stack of blocks. So if you envision a stack of blocks and you push on that stack of blocks from the side, those bones aren't really interlocking anymore and they just kind of slide out of alignment with each other. So that's something that kind of makes children a little bit more susceptible to injuries because those vertebrae just don't interlock quite as well as they do for adults. Additionally, if we look at the ligaments which hold the spinal column together, the pediatric ligaments are more stretchy than adults. So pediatric bones don't interlock with each other as tightly, and the connective tissue that does hold them together is quite stretchy and yielding. So it's not until the person grows up a little bit that those ligaments become more stiff and more substantial. The stretchiness of a child's spinal column is interesting because it kind of poses a unique problem. So when we use the term spinal column or vertebral column, we're referring to all of the bones in the spine stacked on top of each other to form our full spine from head to tailbone. So kind of what you're looking at pictured here. A child's vertebral column can stretch up to 2 inches without injury to the bones or ligaments because those connecting ligaments are so stretchy and so pliable. However, we need to remember that the spinal cord is housed inside of the bony structure of the spinal column. The spinal cord is, of course, the bundle of nerves that controls your entire body. The spinal cord itself can only stretch about 1/4 of an inch before it gets injured. So the spinal cord is very fragile, but for children, it's housed inside of a column of bones that is not really very protective yet because they aren't yet fully formed and aren't held tightly in place. From a medical standpoint, you can end up in a situation referred to as spinal cord injury without radiological abnormality in surrounding bones and ligaments. So it's kind of a mouthful and it's got its own acronym. But if you take a look at this spine on this first photo, a doctor might check the bones for fractures and check the alignment of the spinal column, and they might not see anything that looks obviously broken or damaged. However, if you look more closely, this little white shadow in the center of the spinal column indicates an injury to the spinal cord. 90% of these types of spinal cord injuries without damage to the surrounding bones happen in children under 18 years old. So I'm not a medical doctor. I have to assume that they're trained to look for injuries like this in children, but you can see from these photos that they're a little bit harder to spot on medical imaging results compared to a very obvious fracture of the bones. So now let's talk about how cervical spine injuries tend to happen to children in crashes. The first scenario to discuss is what's called a non-contact injury. It's also called inertial neck injury. This refers to a situation where the crash pulls the head towards the direction of the crash but the head does not contact anything within the vehicle. So here's an example from a frontal crash. And you can see this is just a test setup, but you can see that the head is being pulled forward during the impact. And so what would happen in an inertial neck injury is that just the mass of the head itself pulling on the neck, in some cases, pulls hard enough to cause an injury to the neck. This type of non-contact injury is actually quite rare, but some have been reported. The risk is higher in children than adults due to the things we've already talked about: children's relatively large heads, their undeveloped spine, and their flexible neck ligaments. That big head is pulling on, the little neck, and it's definitely a weak point in the chain. So that's non-contact injuries, but what I want to talk about now is the more common cause of spine injury in children is actually what happens as a result of head contact. So when the head is moving toward the direction of the crash, stretching the neck during the initial phases of the crash, the neck becomes more vulnerable to injury. So the tension on the neck in that stretched position makes it less strong than when it's just in a neutral, kind of normal upright sitting position. So the neck stretches as the crash is happening, and then it receives a sudden jolt when the head strikes against the seat back or the side door. That energy from the contact transfers through the head and into the neck, which can cause vertebral fractures or dislocations or spinal cord injuries. So although neck injuries can happen from just regular pulling forces on the neck, most of them happen when the head strikes a surface and then sends that jolt down through the neck that causes the injury. Injury outcomes change as children age. Younger children tend to have more upper cervical spine fractures, especially dislocations that happen between the base of the skull and C1. This seems to be kind of the weak point in the spinal column for younger children. Unfortunately, injuries in this area tend to carry a higher risk of fatality compared to other spinal injuries. Older children and adults tend to have more lower cervical spine fractures, which are still very serious, but generally not quite as deadly. So what tips can CPSTs put in their back pocket to help caregivers understand and prevent neck injuries? Since, like we talked about, most neck injuries are associated with head contact, one of our main goals here should be, again, to prevent head contact. Preventing head contact will not only protect against head injury itself, but will also reduce the risk of neck injury. So we can kind of kill two birds with one stone here. So the first tip for this is one we all know: encourage rear facing for as long as possible. Rear facing reduces CRS neck forces by keeping the head supported and the spine aligned. So in this way, they help to reduce the risk of those inertial or non-contact head injuries. They also envelop the head in a protective little cocoon, which helps to prevent head contact against the interior of the vehicle. So rear-facing CRS can help to protect against neck injuries due to head contact also by helping to prevent that head contact in the first place. So again, a good fit in the rear-facing CRS is important here, especially in terms of the child's head being at least 1 inch below the top of the CRS shell. For forward-facing CRS, the same concepts that we already talked about for head injuries also apply here. Encouraging top tether use will help prevent head contact, which in turn reduces the risk of neck injury. And again, that top tether saves us about 4 to 6 inches of head excursion or head movement. Anytime we can keep that head away from contacting anything else, we will win in terms of both head and neck injuries. So now let's move on to our last body region we'll discuss today, the legs or lower extremities. If we come back to our chart here, we can see that lower extremity injuries are in gray. They are the second most commonly injured body region for frontal and near side crashes after head injuries, and the third most common in far side and rear impacts. So they account for a significant portion of the injuries that we see from crashes. Injuries in the lower extremities are generally not as life-threatening as some of the head and spine injuries that we've talked about, but as we will discuss, these types of injuries can be very detrimental for children. If we take a look at how kids' lower extremities develop, we find rapid growth rates during infancy and then kind of a plateau in early childhood. followed by another period of rapid growth in adolescence. Limb segments tend to grow at different rates from one another, and we see areas of slower ossification similar to regions in the spine that we already talked about. For example, a child's kneecaps are actually cartilage until they ossify or turn into bone around 3 to 5 years old. So when you're looking at that 2-year-old child who's rear facing and the caregiver is worried that they're not comfortable, you can just tell them, hey, the child's fine because they don't even have real kneecaps yet. Their legs are very stretchy and very bendy, just like the rest of their body. Children's lower extremities also have growth plates to consider. Growth plates are also called epiphyseal plates or physes, and they are areas of cartilage that are weaker than the surrounding bone, ligaments, and tendons. They are the last portion of the child's bone to harden, usually around age 15, and tends to sometimes happen slightly sooner for girls and later for boys. Most growth plate injuries heal with no complications, but sometimes growth plate injuries can increase the risk of crooked or accelerated or stunted bone growth. The severity of these injury outcomes depends on the severity of the injury itself. Some are just inherently worse injuries than others. It depends on the age of the child because, a very young child who still has a lot of growing to do might be more affected over time compared to maybe like a teenager who's just about done growing anyway. And the location of the injury also can affect the severity of the outcomes. We tend to notice that the knee area seems to be the most sensitive. So let's talk about lower extremity injuries and crashes. I want everyone to take a minute to think about, do you think a child, which do you think is safer for a child's legs, rear facing or forward facing CRS? So I think most of us have talked to caregivers who are often concerned about the legs in rear facing mode. They say, oh, they're bent or they're squished or they're touching the seat back, and they want to know if these situations are dangerous for their child's legs, which is a great question. They're kind of looking at the situation and trying to assess what's happening. So these are great questions that we always want to encourage from caregivers. So when they ask about the legs in rear facing mode, a good response for these questions is that we don't have much data for leg injuries in rear facing CRS, but the data that we do have shows that there is a risk of leg injuries in forward facing mode too. So this table is from a paper by McMurray et al. In 2017, and they show the rate of lower extremity injuries in rear facing CRS is about 0.1%, and the rate in forward facing CRS is 0.3%. And these trends are true for children in both their first and second year of life. So just looking at these numbers, we might be tempted to say that the risk of leg injury is greater forward facing because 0.3 is greater than 0.1, and the legs are safer rear facing. In actuality, it turns out that the number of lower extremity injuries in this database that they studied is small. So these sample sizes are not large enough to say that there is a statistically significant difference between this 0.1 and 0.3% injury rate. So statistically speaking, these numbers are equal. But what we can say is that the child's legs appear to be equally safe in rear-facing and forward-facing modes. So turning your child forward-facing does not mean that their legs will be safer. And since we know that there are benefits in rear-facing mode for the head and the spine, we always want to keep the kids rear-facing for as long as possible. So let's explore a little more about how leg injuries can happen in a forward-facing CRS. Here we see an image from a frontal impact. You can see that the head and the arms and the legs all kind of flail forward towards the point of impact. When those legs flail forward, they can hit the back of the front row seat. So the impact against the seat might cause an injury to the legs, or once the legs are kind of up like this and kind of braced against the seat back, sometimes the child kind of continues to travel forward as their torso loads into the harness. And the forward movement of the weight of the body can press the legs into the seat back with a lot of force. So this might also cause some injuries. I was able to find several papers documenting these types of lower extremity injuries for children in forward-facing CRS from real crashes. So we know they actually happen on the road. So when a caregiver says, hey, I want to turn my kid forward facing because I think it will be safer for their legs, you can confidently say that turning forward facing is not necessarily going to protect their legs. There is some compelling evidence that leg injuries can still happen in forward facing seats. And knowing what we know about rear facing seats and how they protect the head and spine, that child is better off rear facing. So to summarize our tips for leg injuries, we want to, of course, encourage rear facing for as long as possible because we know that turning forward facing does not necessarily protect the legs any better than rear facing. We also, of course, want to encourage tight installation of the forward facing CRS and rear facing CRS. Any type of CRS we obviously want to be installed nice and tightly with, of course, the top tether included for the forward facing CRS because that will help keep the child back away from the front row seats and kind of limit the amount that the legs can travel into that front row seat back. So I wanted to show this slide to kind of put things into perspective. So all of the things that we talked about today, everything we know about children and their size and proportions and differences in their bone structure and strengths of their ligaments and tissues, it all kind of boils down to this crew right here. This is the family of crash test dummies that are most often used in the USA. There's a dummy the size of a 12-month-old, a 3-year-old, a 6-year-old, and a 10-year-old. They're all made out of steel and aluminum and rubber and vinyl. And I'd like you to think about all the complexities that we talked about today regarding real children and consider whether these guys are really able to capture everything going on inside of children's bodies. The answer, of course, is no. The human body is vastly complicated and cannot be reproduced in a dummy factory. I also want to point out that these child dummies were originally based on adult data. So back in about the 70s, scientists and engineers took what they knew about adult bodies and adult responses and crashes, and they kind of scaled everything down to the size of children. And this table shows some of the end results of the complicated math that goes into techniques like that. So they're basically taking the proportions and ratios between adults and children and estimating how people of different sizes will get injured. And you can see that there's different sets of numbers for each body region. This table that we're looking at is just the neck. And there are also different reference numbers for whether the occupant was out of position. So this column here, OOP, stands for out of position. So not sitting properly in the seat. And then there's a whole different set of numbers for occupants that are in position. So where they're kind of sitting in the proper upright seating position. And it all gets very complicated very quickly. So even with all this math, they're essentially just taking adult data and scaling it down to fit children with only minimal data from actual children to verify whether all of this is correct. So hopefully after what we learned today, you can see some of the potential problems with this approach and understand why it's important to study children as children and not just treat them as small adults. So I do have to mention, we do have small amounts of data specifically for children. Engineers, when they were building these dummies, they had some idea of what they should look like and how to use them. They're not just completely shooting in the dark. However, it's never as much data as we would like to have in a perfect world, but we're doing the best we can with the information we have. And of course, we have to keep positive thoughts in mind. Child deaths and injuries on the road have been steadily decreasing over the past several decades, which is great. And it's showing us that we're doing a lot of things right, and we're making really great progress as a field as a whole. But the take-home message here is that dummies are simply tools that we can use to help us kind of understand certain things about crashes. And, they're very useful in a lot of cases, but we need to make sure that we understand the limitations of the dummies to really use them correctly and interpret the data that they give us correctly. We also always need to remember to compare back to actual children in actual crashes to see what types of injuries are happening and how they're happening to make sure our dummies are giving us realistic information. For our friends in Europe who may or may not be listening today, I don't want to leave them out. This is the Q series of dummies, which is predominantly, like I said, used in Europe and other places around the world. This family is a little more advanced than some of the other dummies in the US regulations. The exciting news here is that in the US, we are starting to see some of these guys in test protocols, especially the Q3S. The Q3S is a 3-year-old specially designed for side impact. NHTSA just released some information a few months ago describing how the Q3S dummy will be used in our new CRS side impact regulatory testing, which is a really fantastic advancement and will help kids be safer in side impacts. So a good way to summarize our talk today is to remind you that children are not small adults. They grow and change rapidly in terms of geometry and proportions and strength of their bones and tissue. These factors all affect crash outcomes. So scientists and researchers are still learning more about children, and what they learn can help them develop better tools and better CRSs. So while we make progress all the time, we still have a long way to go. So I will leave you with one of my favorite comic strips, which is Strange Planet by Nathan Pyle. If you're not familiar, I highly recommend you check it out. Like we talked about, there's a lot of dynamic factors, and sometimes science is really difficult, but we're all in this together. And you know, as the researchers and scientists and engineers are working towards better products, the work that you all do as CPSTs is really, really critical in that process. You know, an engineer can design a perfect car seat that, you know, responds perfectly in the test crash world, but if a parent isn't using that child seat correctly in the real world, then all of that effort is for nothing. So thank you very much to all of you CPSTs out there who are doing this hard work and making sure that these children are really safe on the roads. We're making great progress, and it's exciting to see more progress that we'll make in the future. So that's all I've got today. Here's my contact information, my email. Feel free to reach out to me anytime, and I'll turn it back over. I think maybe we've got some time for some questions.
Yes, thank you, Julie. That was awesome. We've got a lot of chat comments about how great your information was. So thank you. We do have a few questions, and one of them, I will say that Julie's presentation was recorded, but some people have asked for a copy of your slides. So that was kind of one of the most popular questions.
Sure, yeah, I can definitely share those.
Okay. And then we'll move on to some other questions. So here's one specific to neck injuries. Anyone explored whether a forward-facing car seat provides better protection in side impacts than a booster seat for kids who are in the 3 to 6-year-old age group? And does early transition increase this risk?
So that's a very hot question right now. We definitely want to keep kids in that harness for as long as possible, is, you know, the current recommendations. Data is limited in this area because, like I said, you know, we were looking at the information from the database for lower extremities. We were talking about, you know, lower extremity injuries, rear facing versus forward facing. And even though those injury rates were a little bit different, the sample sizes of that data just weren't large enough to determine a distinct difference in terms of safety between the two conditions. So that's kind of the same problem that we have when looking at like a harnessed seat versus a booster seat in side impacts. Some of the databases, the main databases that we use in the US, just don't really have enough information to distinguish a consistent difference between those two types of seats. And that's not to say that differences don't exist. It's just that so few kids are getting hurt on the roads today, which is great. But, you know, we need a certain number of injuries in both types of seats for us to be able to tell if one is better than the other. And as of right now, the research that I've seen, we're just not quite there. Our databases aren't strong enough. So that recommendation to keep kids in harnesses for as long as possible is based on data, you know, from other areas in the world, which of course, you know, roads in Sweden are very different from roads in the US, and vehicles are different, and driving habits and all of those things are different. So it's hard to compare to data from different countries. And those recommendations are also partly based on testing that's done with crash test dummies. And like we talked about today, a crash test dummy can tell you some things, but they're not great at telling you all the things you want to know. And that's especially true for side impacts. You know, I mentioned we have the Q3S dummy. which is developed for side impacts, but that's the size of a 3-year-old. And so we currently don't really have a dummy that would be the size of a typical booster age child, so like a 6-year-old size dummy maybe. We don't really have that type of dummy yet for side impacts. And so any testing that we do in the crash lab, looking at side impacts between harness seats and booster seats, you know, you've really got to, whatever dummy you're putting in that seat, you've got to remember the limitations of it. And, you know, I know there's been some high profile cases lately where children got very specific injuries in this type of condition. And unfortunately, our technology right now just really isn't quite there yet for us to say whether those injuries happened as a result of being in a certain type of seat or as a result of, you know, something else that was going on in that crash. And so, you know, as a field, we're doing the best we can to advance the dummies and advance the technology and investigate some of these specific crash scenarios. But as of right now, you know, the best information we have points to the guidelines that we all learn as CPSTs and the guidelines that are endorsed by the American Academy of Pediatrics. And that is to keep kids in that 5-point harness for as long as possible before transitioning to a booster. So.
Okay, next question. What is the physiological mechanism that protects small children in rear-facing seat and rear impacts or during the rebound phase in frontal impact?
That's a great question. So in a rear impact, you might expect that a rear-facing child, that seat will kind of rotate. We learned during class, right, that everyone kind of moves towards the direction of the crash. So when you have a rear-facing child, you might expect that rear-facing car seat to kind of rotate upward. So the child's head might kind of move towards the back of the seat that it's installed in, if that makes sense. We actually did some testing on this a couple years ago, and we found that a tightly installed rear-facing child seat actually does a really great job of controlling that motion and kind of absorbing a lot of that energy as the seat rotates. So the rear-facing seat is going to rotate kind of upwards a little bit, but by the time the child's head contacts the seat back or contacts maybe the head restraint or, you know, where people like to hang the little mirrors for a rear-facing child, a lot of that energy is absorbed during that rotational process. And that's especially true for infant seats because of the shape of the base of the infant seat. They really kind of jam into the cushions, and those cushions help to absorb a lot of that impact before the child's head strikes anything with any significant amount of energy. Other things that you see on child seats that might help are like an anti-rebound bar that kind of helps to control the energy as the child rotates. In some cases, these can be helpful. In some cases, like I said, the shape of the CRS itself kind of does the same purpose already. So yeah, those are the types of things that we see really helping rear-facing children and rear impacts. Those are things that we can recreate in the test lab. And it's also important to note that if you look through the databases, both in our countries and other countries of real children in real crashes, that's hard to say. We really don't see too many injuries in that scenario. So typically kids who are rear facing, even if they're in a rear impact crash, like I said, the child seat itself has a lot of really great ways to kind of interact with the vehicle seat to absorb some of that energy. And a lot of times those rear impacts just aren't quite as severe as the frontal impacts. They happen at lower speeds. There's typically some braking involved. You know, not every single one, but in general, most rear impacts aren't as severe as frontal. And so kids tend to do pretty well, even when they're rear facing in a rear impact.
Okay, do you have numbers for how close the 12-month dummy's head was to the top of the rear facing only versus the convertible seats in the study that showed that there may be more head contact for the 12-month dummy in the rear facing only versus the convertible seats?
That is a great question. I actually meant to reach out to Consumer Reports and ask them that same question, and I did not. So yes, I was also curious about that. I suspect that when you put a 12-month-old in an infant seat, the top of that dummy's head was likely near the top of the shell. I do not have the information as to whether it was within that 1 inch or not. But yeah, that's a great question.
Are there any studies being done on children with special needs?
So that's not an area that I have really worked with much. We did do one study looking at actually children in halo neck braces. We actually put a halo neck brace on a crash test dummy, which was really interesting and something that was kind of a learn as you go type of thing. We worked with a neurosurgeon and he was fantastic. In terms of other types of special needs, that's not really something that I have personally looked at. I know there's a lot of really great work going on out there and other places and some really great companies, child seat companies that specialize in those types of products. So I would refer you out probably to others for that specific topic because I know there's some people who do really fantastic job in that area, but I have not done a whole lot yet. So.
Okay, and at what age does a child's C1 develop fully?
Um, that's a good question. I think somewhere, I want to say maybe like the 8 to 10-year-old range. I'm not really sure off the top of my head, but as you could see from the pictures, it definitely, we weren't there yet by 3 years old. So again, the kind of previous guidelines that we'd been given is, rear facing until age 2. But, age 2 isn't a magic number. We see that there's still some weak points in the vertebrae at age 3 and even beyond that. So, that's why it's really important that the new guidelines the current guidelines are to stay rear facing for as long as possible because, there's no real magic age where a child is fully formed and ready to be forward facing. Different bones develop and harden at different rates. And so as long as possible is good to stay rear facing.
And then this, I guess, question kind of goes with it. At what age do the knees become more bone than cartilage?
That's a good point. So the kneecap itself, I think turns into bone around age 5 or 6. But then you've still got those growth plates. So you've got, I can maybe go back to that slide. Let me see if I can find it quickly here. Yeah. So, yeah, on this side, you can see the growth plates are in blue, and you can see that in the knee area, there's just a lot of growth plates because you've got 3 different bones that are kind of meeting here. So you've got the plate on the femur and the tibia and the fibula are all kind of in this knee area. And, these growth plates typically around age 15 is the age that most literature says that they harden, but it depends. It kind of correlates with when the child goes through puberty. So that tends to happen a little bit earlier for girls and a little bit later for boys. But yeah, the knee area tends to be a little bit susceptible until that point, until they kind of get more of an adult type of development.
And are there any recommendations to car companies to design bigger cars to keep kids safe on the road?
That's an interesting question. Not that I know of. I know some cars are getting smaller and smaller as, fuel efficiency and just, all different types of factors are going in. And of course, there's still very large cars on the road too. So I've not heard of anything like that. But it might be interesting to see. And, it's something we talk about a lot in terms of self-driving vehicles and autonomous vehicles. And, we might not need to have the seats set up in the vehicle the same way that they've always been, with the car's driving itself, not everybody needs to be facing forward, right? We can have the cars have the seats kind of sitting in a circle or facing each other or all sorts of different configurations. And so there's a lot of work being done right now kind of considering, well, if we don't all have to be facing forward, what positions do parents want to be facing and do they want their children to be facing? And, how does that work out in terms of, different leg room and different spacing, I guess, around the head and the legs and things like that. So it's interesting, it's still kind of a lot of conjecture at this moment because, we don't have self-driving cars in any significant capacity yet on the roads today. There's certainly a few out there that you hear about, but down the road we might see very, very different vehicle interiors just because, drivers don't necessarily have to be in the driver's seat anymore, and so that opens up a lot of options. So it's interesting, and it's something that we're trying to study and kind of trying to think about before it becomes a problem, right? And kind of anticipate what parents might want and what consumers might want, and try to identify what types of injuries might happen before they actually happen, before we get all these cars on the roads and then say, oops, wait, we didn't think about the kids, they're all getting hurt. It's really important to kind of keep pace with those new developments and make sure that we're thinking about the kids first and foremost, before we make those design changes.
Okay, and let's see, any advice when caregivers talk about how they worry about their airbags hurting their child?
That's a great question. So as we know, in the front row seat, those airbags can be quite dangerous for children. And this was something that we kind of realized back in the 90s. And even frontal airbags in the front row seats have come a long way since the 90s. They can be adjusted, they can be tuned. They're not quite as explosive and as dangerous as those first generation airbags were. So airbags in the front row seats, are coming a long way and doing a little bit better in terms of protecting like teens and elderly people and things like that. But of course, the guidance still stands that children should not be seated in that front row if at all possible. We always want to keep them in the back. And basically, the types of airbags and inflatable restraints that we see in the rear row tend to do okay with child seats. We are starting to see more and more of different types of airbags kind of popping out from different areas in the back row. And so it's something that vehicle manufacturers are definitely checking out, and testing with the child dummies as they kind of develop new airbag technology. But in general, like the standard side curtain airbags that you see in the rear row, those typically don't cause any problems in terms of child restraints or children in the rear row, especially if you think about like older children, like a child in a forward-facing seat, or especially a child in a booster seat. Those boosters are really designed to do exactly what they say. They boost the child up so that not only the seat belt fits that booster child properly, but also so that child can benefit from some of the airbag protection and from different protective features of the vehicle itself. It's another, I guess I should have mentioned that, another one of the reasons why boosters are so difficult to test inside impacts is because that booster age child is supposed to be large enough now to benefit from some of the adult protective features in the vehicle itself. So those side curtain airbags, or the seatbelt itself, and things that are in the vehicle environment that are meant to kind of complement that booster in helping to protect that booster age child. And so yeah, a lot of the airbags that you're seeing in rear rows are perfectly fine with child passengers, and we don't have any data yet that would indicate there's any sort of problem or anything to worry about in that rear row position.
Okay, and last question, and it seems to kind of go along with what you were saying. What rationale can we give parents on why kids should not ride in the front seat? And why is the age 13 the magic number in regards to kids no longer needing to be in car seats?
Great question. Yeah. So in the CRS world, as children are growing, we talk a lot about height and weight and kind of focus more on the size of the child, because the size of the child has to fit within the size of each stage of child seat. When you're talking about airbags and kind of riding in the front row seat, we tend to kind of shift and talk more about age. So yeah, 13 seems to be kind of the magic age, at least in the guidelines. Like I said, there's no magic age when a child wakes up and says, I'm a fully developed adult, right? Like it's very slow over a period of time. But in terms of airbags and front row seat riding, it has more to do with the development of the skeleton itself. So some of these, ossifying different parts of the bones, your growth plates closing, that seems to be kind of a more important factor in terms of when that child is ready to interact with that frontal airbag and with, some of the other features of the front row seat. And also, by age 13, I mean, children still grow past age 13, but, there's short adults out there too. So if you say, you have to be 6 feet tall to ride in the front row, well, a lot of us are going to be excluded from that. So, at some point, children are developmentally, strong, and their skeleton is kind of as strong as it's going to be. And so that's kind of why that front row seat guideline is more based on age and less on size.
Great. Well, thank you so much. That was amazing. We had a lot of good questions and you had a lot of great information for us. Thank you so much.
Absolutely. Thank you.
And thank you to everybody that joined. But that's the end of our main session for today. You may see your participant packet for connection information. It's on page 3. So for the next sessions you want to join, make sure you go to page 3 in that packet. The next 2 sessions coming up, one is worth a CEU, and that is the panel, and the other one is not worth a CEU. So make sure you look and see which one you want to go to. Please close out your browser completely before clicking the link to join the next session. And if possible, try to join your next session before stepping away to take your break. Thank you so much, and we'll see you in just a little bit.